My pleasure to introduce Professor Marwa Abdullah. She is a professor of dermatology at Ain Shams University in Cairo. And she has been a professor since September 2009, head of the phototherapy unit since 2006, and head of the Vitiligo clinic since just 1 year. Marwa and her family have a private dermatology clinic, and vitiligo is her passion. Go ahead, thank you.
Thank you for the intro. Yeah, it's the end of the day. I can see everybody is very tired. I will talk about the updates in the surgical management of vitiligo. So, these are my conflict of interest. My disclosures. I don't have any conflict of interests. The surgical treatment of vitiligo is divided into melanocyte transfer and other surgical interventions like lasers, plus additives, microneedling, micropigmentation, which is the tattooing, the medical tattooing. In this presentation, I'm going to talk only about the melanocyte transfer surgeries. In general, when we do surgery, we depend on the melanocyte migration so that we put a small piece of tissue to cover a bigger recipient area. And the surgical treatment of vitiligo is divided into tissue and cellular suspension. The tissue grafting includes mini grafts or the punch grafts, follicular grafts, epidermal grafts, which are further subdivided into epidermal sheet grafts or ultra-thin tierce grafts, blister and the blister grafts. And lastly, there is also the follicular grafts. On the other hand, the cellular suspension include non-cultured and cultured suspension. All depend on exportation of the melanocytes to deficient areas, and they have all to be done on stable vitiligo, whether it is segmental or non-segmental. Both have to be stable for at least 1 year. The historical timeline of vitiligo surgery started 75 years ago, where Haxthausen started by tierce grafts as an experimental model, and over the years, lots of developments have been done and are still being done. The updates and modification in surgery in the last 20 years involved cost-effective, easy-to-perform procedures, which are less time-consuming, leading to better repigmentation and a better cosmetic appearance. The modifications are in donor preparation, recipient area preparation, carrier or media of the suspension or whatever we're going to use, and the dressing. What are the predictive factors for surgery success? We always tell the patient the repigmentation may be between 50 and 100%. The segmental vitiligo yields better results than the generalized vitiligo. Young patients have better than old patients' repigmentation. The dark skin repigments better than light skin, and the best results you always get on the face and neck, and the worst on the hands and feet. Classically, we do positive mini-graft testing, which is putting some grafts and waiting for about 4 months and looking at the outcome of this technique before proceeding to covering large body surface areas. Here you can see up is negative mini-graft test. No, the color is lost and there is erythema. And down is the positive repigmentation with melanocyte migrating out of the mini grafts. What are the updates on the pre-surgical predictive parameters? We have heard today about CXCL10 as a marker for activity and CXCL9 as a marker of activity. How about their role in surgery? Actually, we measured the CXCL10 in patients with short stability and those with long stability. And it was not significantly different between those with short and long, and it was not helpful. However, the mini-graft test done to the same patients showed that it was more helpful in detecting who will benefit from surgery. Another way is doing a blister fluid analysis for CXCL9. And this is a local marker of inflammation. If the CXCL9 is high in the blister fluid, that means no surgery. Last but not least is immunohistochemical detection from perilesional skin of mini-graft testing using CD8 and CD45 RO stains, and cells less than 7 CD8 and 11 CD45 RO in the per high power field mean better survival and better repigmentation. So we have these three objective parameters nowadays. Let's start by tissue grafting, the punch grafting or the mini grafting. It is easy to perform. It is an office procedure. And you can see the melanocyte migrating out of the cells as, or of the grafts, as you can see on this middle picture. However, cobblestoning is one of the major side effects of the punch grafting. The updates include how to overcome cobblestoning by using smaller punches, 1 millimeter or less, to decrease the cobblestoning, harvesting the cobblestone and using them to treat an area, and adding silicone gel was tried, but it proved that it induces earlier repigmentation but had no effect on cobblestoning. The use of motorized mini grafting, and it has been shown yesterday in the workshop, 0.8 millimeter and 0.5 millimeter punches, and using the 0.5 millimeter punches in any direction, not taking care that the epidermis is up, resulted in positive repigmentation. Weekly transverse needling after mini grafting led to a greater extent of depigmentation. Of repigmentation and better color match, and adding platelet-rich plasma also helped earlier repigmentation but had no effect on the end result. The hair follicle in vitiligo surgery serves two ways. First, follicular unit extracts are useful in repigmenting hair-bearing areas, and second, the bulge area of hair follicle contains stem cells and is a good potential for suspension grafting. The updates on hair follicle transplantation include harvesting the follicles without the bulb will result in repigmentation and regrowth of the hairs, but the hairs will regrow thinner. And if we take the hair follicle and cut it into two, we can, both sides, upper and lower part, will result in repigmentation, and we have more grafts for covering a larger area. Now let's talk about tear grafts. The tear grafts originally were used to be larger than the vitiligo area because of shrinkage of the grafts after taking. And the concept of melanocyte transplantation, melanocyte migration does not apply very much here. Cosmetically, it doesn't need to a good outcome. So what are the updates in tissue grafting? When we cut this tissue grafts to very small sized grafts, which is called smash grafting, and making a dough with it with some saline and then spreading it on a dermabraided area, it leads to repigmentation, and in this case it will depend on the melanocyte migration. The meek grafting is nothing but using the mesh graft that is used in the mesh graft machine that is used in burns and to correct the burns, and you cut it and put it on a pleated gauze, and then when you spread the gauze out, you have a lot of small grafts here on the right, from which the melanocytes will spread out and cover the area. Suction blister grafting. The suction blister involves using something to apply on the skin, either syringes or cups, and a suction apparatus, which is either a machine or a 50 milliliter syringe, as we did yesterday in the workshop, and we wait for 1 to 3 hours for the blisters to come out, and then we cut them and apply them on the dermabraided skin, and we apply the dressing and close it for 1 week. All body sites can be treated, including eyelids and lips. And the procedure is difficult to perform on certain areas like body folds, acral areas, and palms and soles. Here is a demonstration of our work. On the left are the knees showing total repigmentation, and on the right, 3 parts of the hand was treated by blister grafting. The thumb and the index finger show repigmentation because they had their depigmented area a little bit low, and on the left, the ring finger didn't show repigmentation because it is a distal part of the acral areas. So, use of cupping. They are called Chinese cups, Korean cups, or hijama. And they are all the same, referring to the same thing, which is using cups 2 to 7 centimeters in diameter. They get larger grafts. However, they take a longer time to develop, and hemorrhagic blisters may appear, and multilocular blisters may appear. So, the modifications done are putting a divider at the base of the cups to get multiple small blisters and save time. Comparing and using automated blister grafting using the Cellutome resulted in less harvest time, greater transplantation zone, more rapid donor healing time, better patient's experience, but it was more expensive, and the outcome at the end of patients treated with the manual suction or the automated suction was the same. Another update is using suction blisters for non-cultured epidermal suspension grafting in patients with vitiligo. Instead of taking tissue grafts, you just take the epidermis with melanocytes and transplant them. This is an objective study comparing different sizes of syringes, different sizes of cups, and seeing the suction blister time to develop them. And the smaller ones, of course, had a shorter time. And the preheating decreased the suction blister time, and use of saline treated the multilocular blisters effectively. Let's spend some time with the cellular suspension grafting because this is the most used tool. It includes cultured and non-cultured and stem cells. And the cultured is either pure melanocytes or melanocyte keratinocyte transplantation. And the non-cultured includes epidermal and follicular or mixed suspension. The cultured melanocyte transplantation, when it was there in 1987, we were very happy to have a small piece covering the whole body, but the use of growth factors being oncogenic and the need for special labs and trained personnel and the expenses made them not very popular. However, the cultured techniques may be a perspective in providing stem cell transplantation in the future. The non-cultured epidermal suspension is done by taking a graft from the buttocks or from the side of the leg or the thigh, and you can use this dermatome or you can use the razor blade. And then you wash it, you put it in trypsin and incubate either warm incubation for 30 to 50 minutes or cold incubation overnight for 18 hours in the fridge. Then some people use a trypsin inhibitor. You wash 2 to 3 times, separate the epidermis from the dermis, discard, and then centrifuge and take the pellet and apply some PBS or any medium on top and apply it on the dermabraided area, and then apply the collagen sheets or sterile Vaseline and bandage for 1 week. The updates in non-cultured melanocyte transplantation or non-cultured epidermal suspension include things that overcome the challenges or the obstacles that we see during the procedure. So if you don't have trypsin, what to do? You can use the harvested cells during a motorized dermabrasion like the one done by Jodhpur in 2008. And they mixed them with antibiotics and put them on another dermabraided skin, the vitiligo skin. And in 2020, El Garhi et al. Modified the Jodhpur technique by adding the harvested cells in a patient's plasma gel. And there is also, we can use epidermal curettage instead of dermabrasion and take the curated cells and apply them to the curated vitiligo skin. What if you don't have an incubator? You can leave it at room temperature, especially if you are having a warm environment, as in our country, for example, or here in India. Or you can use the patient's axilla, where you put the tear graft or the graft that you have taken in an Eppendorf tube with trypsin and put it under the armpit of the patient and wait for half an hour, and then it is ready to be transplanted. What if you don't have a centrifuge? You use the 6-compartment method or the 4-compartment method. The 4-compartment method, it is a petri dish divided into 4 parts. The first, you trypsinize. The second and third, you wash. And in the fourth, you separate the cells and throw the stratum corneum, throw the dermis, and use it for transplantation. The other updates are about the suspension medium. All these suspension media have been used in non-cultured epidermal suspension, including saline, PBS, ringer lactate, DMEM, hyaluronic acid gel to increase the solidity of the cells, patient's own serum, plasma gel, using a preset kit. All these can be used as media. The optimal donor-recipient area for our recipient ratio for non-cultured epidermal suspension ranged between 1 to 3 to 1 to 10. Which is the best? This is a very nice comparative study comparing 2 groups. One was treated with 1 to 3 ratio, and the other was 1 to 10 ratio. And group 1 was better than group 2 as regards the percentage of repigmentation, excellent response, excellent color match. This result was seconded by a systematic review in 2021, and they showed that the best ratio is 1 to 3. Now, the recipient area. The recipient area should be a good soil for implantation of the melanocytes. There are different ones. The cryoblebbing, which was first introduced by Gauthier et al. In 1992, where we injected the material inside the cryoblebs, and they served as a biological dressing, and closed it, and you wait, and then it repigments from this area and spreads out. Manual dermabrasion, motorized dermabrader, which is very easy and not expensive. Ablative lasers like erbium YAG or CO2, fractional CO2, dermastamp or dermaroller, microneedling, ultrafulguration, sandpaper even can be used, and hypodermic needle can be used to scratch the skin and prepare the recipient area. Benzekri and Gauthier in 2017 showed us a very nice model of doing dermastamp, and this dermastamp is 0.2 millimeter length needles, and the melanocytes in the epidermis showed repigmentation, but those which reached the dermis were killed by the CD8 positive T cells. Microneedling, electrofulguration, and cryoblabbing are good. The best are electrofulguration and cryoblabbing. They are better than microneedling. Ablative CO2 versus cryoblabs in a study showed CO2 induced more homogeneous pigmentation. CO2 was better for elbows and knees, but the cryoblabs were better for the fingers. Using fractional CO2 or totally ablative CO2 in recipient sites, they show both were good and got a very good repigmentation. The dressing, you can use collagen sheets, which are very nice and aid the repigmentation. Vaseline goes if you don't have collagen sheets, or you can use the role of the suction blisters as a biological dressing. The follicular suspension grafts, as we said earlier, the bulge area and the bulb, they have melanocytes that can be used, and they were thinking that they will get a better result because the melanocytes are larger and more active, and they have remarkable synthetic capacity. The extracted hair follicle outer root sheath cells have CD200 positive marker. The hair follicle-derived stem cells alone in many comparative studies were not superior to the epidermal suspension, and the epidermal suspension is easier to perform. But mixing the follicular suspension with the epidermal suspension got much better results in a right-left comparison. This is because the keratinocytes supply the melanocytes with growth factors like basic fibroblast growth factor, endothelin-1 stem cells, and others. And the mesenchymal stem cells that are present, they have an immunoinhibitory effect halting CD8 positive T cells. What is the fate of transplanted tissue after years of surgery? The follow-up studies up to 13 years showed preserved repigmentation, and some studies have shown that even if general relapse of vitiligo occurs, the grafts were frequently preserved. And there is a good to excellent repigmentation in 83% at 5 years. And the relapse was less in patients with small body surface area, long stability duration, and mechanical dermabrasion. And the increased relapse was seen with non-segmental vitiligo and the fingertip involvement. What are additive therapies to non-cultured epidermal suspension? Phototherapy before and after, using sun, narrowband, Xymer, Buvasol. We started usually 2 weeks after surgery. Sometimes patients who are already on phototherapy, we include them, and they also have very good results, and we continue after the surgery with phototherapy. Topical therapies, tacrolimus or steroids after therapy are helpful. Tacrolimus is more preferable because it is a melanocyte stimulant, not only an immunosuppressive. And systemic steroids and other immunosuppressants have been tried in not very stable cases, and there is positive repigmentation. However, the long-term results are not there. Cyclosporin given post-operatively at 3 milligram per kilogram body weight in a study showed that patients repigmented better, and there was no perigraft halo, which is one of the most serious side effects we all encounter when doing any type of surgery. Also, microneedling and 5-fluorouracil done 2 weeks before non-cultured epidermal suspension improved the outcome of acral vitiligo. What are the unmet needs in vitiligo surgery? We have talked about it in the morning for vitiligo in general. Here, the unmet needs are treating patients with short stability surgically. Some patients never reach 1 year stability, ever. So this is a challenge. Another part is treating special sites like the periangual area or the sides of the hands and feet, the genitals, treating leukotrichia, especially of the eyelashes, the scalp and the eyebrows. All these are unmet needs. We need to find a solution for them. The future, stem cells. What are the types of stem cells? We have embryonic stem cells and inducible pluripotent stem cells. These have a tumorigenic potential, but the mesenchymal stem cells present in the hair follicle, dermal stem cells, bone marrow, and adipose-derived stem cells, they have they can be transformed to melanocytes, and they have an immunomodulatory properties, so they can be used. And there was a pilot study using the dermal suspension and non-cultured epidermal suspension together with good repigmentation. What is the future? Multilineage differentiating stress-enduring cells, shortly called Muse cells. The Muse cells comprise a small population of the mesenchymal stem cells in the bone marrow, dermal fibroblasts, and adipose tissue. They do not undergo tumorigenesis like the pluripotent stem cells or the embryonic stem cells, and they can differentiate into ecto and endo and the mesodermal lineages spontaneously and under stress, so there may be a future for vitiligo surgery. So in order to recap, we have the surgical treatment indicated in stable cases of segmental and non-segmental vitiligo. The use of tissue or cellular suspension can be used according to the doctor's preference, the patient's preference, the availabilities, etc. The sites that can be treated, sometimes we treat a patient in his eyelids by suction blister and in somewhere else with non-cultured epidermal suspension, etc. And the real future is in networking and working together and having discussions and workshops and growing bigger and bigger as a family of surgical treatment in vitiligo. Thank you very much.
Thank you so much, Dr. Marwa, for this excellent presentation. Is there any question? Yes. Dr. Gauthier? Yes.
Dr. Gauthier.
Thank you for your excellent presentation, complete. And what's about actually your favorite technique for eyelids and lips?
My favorite technique for eyelids is suction blisters. I do always suction blisters, and I prepare the recipient area by a totally ablative CO2, a carbon dioxide laser, because it is less, there is less bleeding with it, and it gets a very good result, actually. We have been working with erbium YAG laser before that, and it was very bloody, even if we used xylocaine adrenaline. For the lips, actually, I don't do lips. They have been a failure for me. We did yesterday a case with non-cultured epidermal suspension, and let's hope that they get good results. And I believe what we did yesterday, I don't know how to do it. I learned it yesterday to put to tie in the dressing so that it doesn't move. You know, they just got stitches and they tied it on it. Where's Dr. Sani? She's sitting here right here. She taught me yesterday. Okay. So I will start it when I go back.
In 92, I use blister induced with liquid nitrogen, but in 92...
Actually, this was my first thing. It was my thesis. I was comparing mini grafting to your technique, and your technique was giving very nice pigmentation without cobblestoning, but it was a bit blotchy. You had to have lots of suction of blisters next to each other so that they merge later on. So when we did it in close, they were giving very good results, but it was a bit painful for the patients, and the patient had to come twice.
Marwa, good job and good talk.
Thank you.
Regarding using the phototherapy after the melanocyte transplant, anecdotally, we don't do it because we might think that it might affect. But I think Samia here, either she or one from Egypt, they have good study that show phototherapy post-melanocyte transplant will not add anything, and it might negatively affect the melanocyte that you have transplanted. What's your comment?
I do it.
It's the opposite.
No, you have earlier
Sorry?
repigmentation.
Do you use phototherapy after melanocyte transplant?
Yes. It works very well.
Sanjeev Molekar, he always discouraged using any
Yes,
You
he
know
doesn't
him.
like it, I know.
Yeah, so anecdotally, we don't use it. So this is why I thought, but is there any study in Egypt that phototherapy will
That I
add?
know of.
I think there was a study, whether it is positive or negative.
No,
Because
we
this is
have-
very important issue for all of
should-
us.
We
Yes,
should
we
do
have a study, but it was not after phototherapy. It was before phototherapy, where we were trying to increase the melanocyte activity in the donor site. And it really increased the amount of active melanocytes in the donor tissue.
But do you use phototherapy after?
Yes, of course. I
Do you
use
have
it
any
always.
data that
Yes,
adding
you
phototherapy
know,
is good?
The week the patient
And
comes.
But there is
Dr.
no data.
Bezekri
Doctor,
just said
the day-
that
You're
Excuse me,
right.
sir. It was
He's
my
right,
thesis,
there
Dr.
is.
Ahmed. Dr.
There is
Ahmed
a-
here. It
there
was
is
my
a
thesis,
paper.
Dr. Samia Aismat.
Yes.
Yes, it was my MD thesis.
Yes.
I have used with some cases phototherapy and the other cases without phototherapy and with no significant difference
Yes.
between both groups.
So
yes,
Yasmin
right.
approves the
Yes, this is approved. So I think,
I
yeah.
think
I was
Thank
in
you.
defense.
Thank you.
There is also another paper about this, that the outcome of phototherapy plus surgery is exactly the same without phototherapy. But you have an earlier
Earlier
repigmentation.
repigmentation. Maybe it's the same paper from Yasmin Tawfiq?
No,
I-
no, it's another paper.
I have a question for you, Marwa.
Yes.
Nice lecture. I always use phototherapy after transplantation, but my question to you is, do you think that if we artificially induce stability with phototherapy, let's say for 1 year, and they're stable, in a person who has a history of recurrences previously, why can't we, and I have 600 people with home phototherapy, okay, so it's not a problem for them to come to my clinic. How do you feel about having continuous artificial stability induced by phototherapy once a week, or, you know, like a maintenance phototherapy afterwards? Do you think that transplantation with artificial stabilization by a physician is something that's reasonable, or do you think that that's not?
I think it's reasonable and we should try it. We should do a study about it. Yeah. Okay, thank you very much.